Thank you everyone for hanging with us this morning. We have our very last speaker and another one of our experts. I'm going to give you a quick introduction, Dr. Baker. All right, so Dr. Christopher Baker is board certified in orthopedics by the American Board of Orthopedic Surgery and fellowship trained in sports medicine and shoulder reconstruction. With a focus on patient education, Dr. Baker works with patients to ensure they fully understand their orthopedic options and outcomes. Dr. Baker's additional training in ultrasound imaging allows him to care for patients who have MRI contradictions due to pacemakers, foreign metal in their bodies, and severe claustrophobia. Please help me introduce Dr. Baker.
All right, thank you very much. So a little start on me. I changed my name to Baker because Armagani was too tough, so that way I could make it easy on everybody. So my name is Chris Baker. I'm with the Florida Orthopedic Institute in Tampa, Florida. I'm also associate professor at the University of South Florida, so we train the residents and the fellows there as well. I did my training at the University of Pittsburgh, where I got to work with the doctors that take care of the Steelers and the Penguins and all the other colleges and high schools in town. I then went on to do a sports medicine and shoulder reconstruction fellowship in Greenville, South Carolina. I got to take care of many of the baseball teams in town, and I got to take care of the Rockies for a little while. I'm currently board certified in orthopedic surgery. I have a certificate of added qualification in sports medicine and shoulder reconstruction, which is just additional training in these types of things that we'll be talking about. There it is. So shoulder pain. Anybody in here ever had shoulder pain? All right, good. All right, so there's plenty of takers. All right, so shoulder pain is not a normal part of aging, okay? I get people that come to me all the time, and I'm like, how long has this been going on? Oh, it's been a year. What have you been dealing with this for a year? What have you done for it? Nothing. Anti-inflammatory, nothing. Have you seen a doctor? No. Shoulder pain is not normal. Everyone kind of comes to me and say, oh, I just thought it was normal. But patients come to me for all different reasons. They'll come to me for shoulder pain or arm pain. Some people will describe pain on the side of the arm and they don't think it's their shoulder. That's actually a commonly referred symptom, is pain on the side of the arm. A lot of patients will come to me once they finally start losing sleep, so they'll deal with shoulder pain at work and throughout the day, but when they don't sleep, they'll come in, or their spouse can't sleep because they keep hearing their spouse roll over in bed moaning and groaning. Other people come to me for stiffness. I can't put my wallet in my back pocket anymore. I can't tuck in my shirt. I can't put my belt on. Other folks, it's more activity related. It hurts when I throw. It hurts when I lift weights. And then lastly, people come to me because they think that their neck and their shoulder are kind of the same. And so they'll come to me for neck pain, and then I'll send them to Dr. Armagani and I'll say it's not your shoulder. There's lots of reasons for shoulder pain, and we'll try to hit on kind of the most common ones. The most common reasons I see people for shoulder pain in my practice is something called impingement. We'll go into these in a lot more detail throughout the talk. Impingement, tendonitis, bursitis, bone spurs, those are really all the same thing. Biceps tendon injuries are another common reason I see folks. Rotator cuff tears, arthritis of the AC joint or the ball and socket joint of the shoulder, patients with a frozen shoulder or adhesive capsulitis that have painful stiffness, calcific tendonitis, and then fractures. Those are the most common reasons that I see folks for shoulder pain. We have to do a little bit of anatomy so you'll kind of have an idea of what we're talking about here. So I hate to take you to school, but we'll go through this a little bit. If you look at the ball and socket joint of the shoulder, it's really just a large ball and a tiny shallow socket, okay? And what you gain by having a large ball with a small socket is you gain motion. The shoulder is the most mobile joint in the body. You have a lot of degrees of freedom there. The problem though is that because of that motion, we rely heavily on the soft tissues around the shoulder to balance that motion and keep the shoulder stable. So that's why we have so many injuries in the shoulder, is because of the inherent instability of the ball and socket joint. Above that ball and socket joint is a little bone called the acromion. You'll see at the very top here. I call that the roof of the shoulder, and we'll discuss some pathologies that occur there. As we go more shallow now, leaving the shoulder and going to the outside, we have something called the labrum. The labrum is really just a gasket of tissue that goes around the socket to make it a little bit deeper. It's a fibrous cartilage that makes it very tough and strong. And then the joint capsule, which is that kind of thin lining that you can see there that's almost like a grayed out area, that capsule actually nourishes the cartilage. It nourishes the cartilage and the tissues within the shoulder, and those are two other areas of injury that can occur. That's usually something that we see in athletes as labrum injuries and those types of things. Then the most superficial picture here is the muscles of the rotator cuff. There's 4 muscles and tendons that keep that ball in the socket. They help stabilize the shoulder as you move the arm through space, and those are another area that are commonly injured. When we look at the most common thing I see in my office, it's my version of low back pain. For some reason my clicker is not working. Am I out of range maybe? Can I just have you advance maybe, or did it come out? All right, so impingement is the most common thing I see. This is my version of low back pain, okay? So the average person that comes into me, they have pain in their shoulder. put the new one in. Thank you. They have pain in their shoulder, and this is called lots of things: tendonitis, bursitis, bone spurs, impingement. They're all the same thing, and what it literally is true pinching of that rotator cuff underneath the roof of the shoulder. So as the patient raises their arm in the air, the bones of the shoulder pinch here, and they pinch this little lining and tissue, which is highly innervated and inflamed, and that's called bursitis. Why does it occur? Some patients have a true bone spur. The bone grows over the edge as a result of pinching into the shoulder over time, and then that can cause pain. Other folks have weakness of the ball and socket joint, and if you have weakness of the rotator cuff ball and socket joint, that ball rides up into the shoulder and it rubs along the roof of the shoulder. That's the most common reason that I see it. Other folks, their anatomy is just a little funny. That bone, which should be straight, curves down, so obviously as they raise that arm up in the air, they're more likely to pinch into that. We still typically call it a bone spur, but if normal for that patient, it's just become pathologic for that patient. What do we do for this? Luckily, most of our patients are treated non-operatively. Anti-inflammatories, again, are the workhorse for us. This is a cortisone shot that we're doing here for the impingement. But therapy, much like low back pain, therapy, anti-inflammatories are the real key to this. Patients who have really severe pain are the ones that get these cortisone shots. You can see the patient didn't jump or move. If I did volume on here, she doesn't make a sound. It's not a painful, terrible process. It can take someone who can't sleep at night, who can't do their job, and we can get them right back to work the minute after that shot, okay? As we go to this next video, this is if we have to go in and remove that bone spur. So he's going to advance this for us. This is an arthroscope. We're doing this through little 1-inch incisions in the skin, and we're taking this little burr, and we're actually taking that bone spur, and we're just going to smooth it off. My wife told me not to put any bloody stuff in here, so they're all relatively clean pictures. I don't know if there's anybody queasy in the room here. But basically, that's all we're doing. We're taking this little burr. I'm a woodworker. I mean, that's basically what I do. I go in and I remove lumps and bumps, and I tie things down. That's really what I do. So as we get in here, we take off this bone spur. Once we get it nice and smooth and flat, as that patient raises their arm in the air, they're no longer going to pinch against that bone spur. Hopefully that might even prevent a rotator cuff tear, although we can't really prove that. It's a tough study to make. So that's the surgical side. That's less than 5% of those patients that come to me for that shoulder pain that ever need to have any kind of surgery, injection, therapy, and then they're on with their life. The biceps tendon is another problem that we deal with a lot. There's two biceps tendons. Obviously, that's why it's called bi. There's one tendon that comes here in the front of the shoulder. Then there's another tendon that actually ducts into the shoulder itself. It goes underneath the rotator cuff and onto the top of the shoulder, and it makes that lining called the labrum around the joint. That's the one that becomes injured. This one almost never becomes injured outside the shoulder. Why does that occur? You could be playing catch or something like that, throw, fall on it, whatever it may be, that you get a resistant load to that biceps tendon, it can pop on you. Other people, when you get arthritis and bone spurs, it pinches that biceps tendon. That can cause you to have pain. And then other people just have genetic breakdown of the tissue. It just slowly breaks down over time. So what we do for that? Biceps tendon, again, are generally treated in a non-operative manner. Great, go ahead and play on that video. Most of the time, these are treated non-operatively. I think it is playing. There you go. Again, anti-inflammatories, injections, and therapies. This is actually an ultrasound. So you'll see I'm coming in from the top left here. We're pushing a needle in, and I'm watching it with that ultrasound. We're going into the shoulder. Again, the patient's not in any major pain. We're doing this very quickly in the office so she can go home and feel better. And then therapy to correct whatever abnormality is going on in the shoulder. Surgical intervention is much less common. This is a gentleman who has what's called a Popeye deformity. So he tore his biceps tendon, and now he's got this bulge. You'll notice that the inside tendon is still intact, so that biceps tendon is still good, but the outside part is what is torn. This happened to John Elway. He threw in the Super Bowl, never had it fixed, MVP. I commonly tell patients when they come into me with this injury, John Elway didn't need it, you don't need it, okay? If you want to have surgery for that, it's possible. The surgeries that we do for those types of things, one is called a tenotomy, where we literally just go in with a scope and cut the tendon. Here we're passing a tendon through the a stitch through the tendon with a little needle there, and we'll come in with a big pair of scissors and we'll cut that tendon. For folks who don't want to have that deformity or that bulge, we'll do something called a tenodesis, where we'll actually move it out of the shoulder here, and we'll take it from inside the shoulder down into this little groove, so it's no longer traversing the ball and socket joint, and it's not seeing those forces that are causing the pain on it. That's more commonly what I do. Most people want to have a normal looking arm. I would, so that's usually what we do. Rotator cuff tears are the thing that most of us hear about. That's probably one of the fewer kind of things I see in a day. It's not all that common, although it is very ubiquitous in our culture. It is called the rotator cuff, not the rotary cup. Rotary cup is probably the most common thing I hear, but it's actually called the rotator cuff, and it's literally just a cuff of tissue. It's all these muscles that become tendons that surround that ball and socket joint. So it's called the rotator cuff. This is actually true tearing of that tendon. It's not just being pinched anymore, it's beyond that point. It's been pinched so hard or damaged so bad that it's actually torn. This can happen from an acute injury. You're walking through your house, you slip on a wet floor, and boom, you got a rotator cuff tear. Repetitive activity could cause this, repetitive overhead activities that are continually pinching that shoulder into the bone spur. That's called impingement. And then we think that the majority of these are actually just a normal part of aging. As you get older, the tissues break down, much like in the disc, like Dr. Organi talked about. As the tissue breaks down, you get a tear, and it may become symptomatic. The thing about the rotator cuff tears is that the incidence or the frequency in our culture is very, very high. So if we were to do an ultrasound or an MRI on everybody in this room, we're going to find a lot of rotator cuff tears that you don't even know about, okay? That's why I'm actually a little bit slow to get MRIs, because we might not be treating you, we might end up treating that MRI. It's to the point that it's been so well studied here that if you look at patients, just as you get older, your incidence and chance of having a cuff tear gets higher. If you look at any of these studies, over age 60, you have a 20% chance of having a rotator cuff tear, even if you don't have pain. So you're sitting here, you think you have a normal shoulder, 1 in 5 patients are going to have a rotator cuff tear. Look as you get out of upwards of 80 years old. Half of patients over the age of 80 have a rotator cuff tear and have no idea that they have it. Okay, and so for that reason, we tend to be very conservative when we treat shoulder pain. Almost always it starts with a cortisone shot. Almost always it starts with physical therapy. If there are red flags, that's when we start getting MRIs and ultrasounds. When we look at this, the way that we manage rotator cuff tears, now we've diagnosed that you have a rotator cuff tear, or your primary care doctor ordered an MRI, and you come to me and you have a rotator cuff tear. That's actually the majority of the time that I spend with patients, is kind of educating them on now what, okay? Because now what is not always going to the operating room. A lot of times we can take care of things on their own. But there's 3 facts that we need to make sure the patient understands before we make the decision on whether we're going to fix it or give them a cortisone shot and therapy. The first fact is that rotator cuffs really do not heal on their own. There's very little evidence that a full thickness rotator cuff tear can ever heal on its own. Number 2 is that many rotator cuff tears can get bigger. Over 4 years, a small asymptomatic cuff may become painful, and those patients may end up needing surgery. And then number 3 is that at some point in time, that tear can get so big that I can't fix it anymore. And then we're getting into more advanced surgeries and replacements and those kinds of things. So what we do for these patients is really based on who they are. This is a rotator cuff repair that we're doing through the scope here. Anti-inflammatories, non-operative management, injections are a little less common here. Once we've already kind of failed that gambit, now we're marching down the process of surgery. Older patients who are less active, who have bigger tears, are more commonly treated non-operatively. Younger patients with smaller tears who are more active are more likely to get surgery. Surgery comes in this variety. Usually we're doing this through an arthroscope these days. If you have a younger shoulder-trained doctor or sports-trained doctor, they're going to do all this through the arthroscope. Very rarely will we need to do this open. Arthritis is the next thing that we see, somewhat less common because we don't walk on our hands, although the incidence is very high. There's lots of shoulder arthritis in the world, but not nearly as bad as the back or the hips or the knees, because those are weight-bearing joints. Obviously, you're breaking down those joints. Arthritis can occur from genetics, just from a natural part of aging. So you have your knee replaced, your hip replaced. It makes sense to think that you probably have arthritis in your shoulder too, so that's a genetic predisposition. Injury can occur that can cause you to have arthritis. So you have a dislocation as a kid, you play football, it comes out 3 or 4 times, you're at a higher risk of having arthritis as time goes on. And then the last thing that can occur is if you have a rotator cuff tear and that ball is bouncing around in that shoulder, it's just scuffing the cartilage. So if you have a large rotator cuff tear, a lot of those patients end up getting arthritis as well. What do we do for those? 100% of those patients in my practice are treated non-operatively to begin with. There's no doctor that you walk in and say, hey, I have arthritis, that should be replacing anything on you. There should always be some effort at non-operative management, whether it be your knee, your hip, your shoulder. If you walk in for the first time to see an orthopedic surgeon and say, I have arthritis and I didn't know it until you just told me, and they say you need a replacement, you might want to get a second opinion, okay? There's a lot of options that we can do. Most of my patients that I give a cortisone shot to for arthritis of the shoulder essentially walk out pain-free, and they're super happy. They might still have some stiffness, but they're very happy. Operative is once they have failed those non-operative measures with injections and therapies, then we start to march down that path of surgery. And that happens about half the time over a period of 2 to 3 years. This is an open shoulder here. You can see we actually have to pop your entire shoulder out of the body there in order to do our surgery, and then we'll put this metal and plastic in there. When we do surgeries for replacements of the shoulder, there's lots of varieties of types of replacements. This is called a partial total shoulder replacement, where we're just resurfacing the ball, and then the cup is the native cup of the patient. Usually it's going to be done in someone that's younger. This is a standard total shoulder replacement where we put a stem down into the bone, put a new ball on top, and then there's actually a plastic socket in here that you can't see on x-ray. And then something called a reversed arthroplasty, where we actually have to take the ball, which is normally on the side, the head side. We have to put the ball on the socket side and then put a socket on top of this tray. That's something that we do in patients that have large rotator cuff tears, because if we do a regular replacement in someone with a rotator cuff tear, it'll just dislocate and come out of the shoulder. So there's something called a standard total replacement or anatomic, and then there's the reverse. Frozen shoulder is another thing that I actually see a whole lot of, and this is probably the most common thing that I see that's missed by a primary care doctor or another orthopedic surgeon. The patient comes in, they have some benign injury or maybe no injury at all, but they notice that they have pain whatever they do. Like they can't reach behind their back, they can't reach in their back seat, they can't put their arm forward. If it's stiff in more than 2 planes, then it's either a frozen shoulder or an arthritic shoulder. Frozen shoulders can happen out of the blue. That can happen from a small injury. Your doctor puts you in a sling because you hurt your shoulder, and then you run around with an inflamed shoulder that's now stuck there because you've kept it there too long and you can't move it. The other thing that can happen is something called autoimmune disease, where people with diabetes or thyroid disease or lupus, they have a small injury, and this nice happy capsule, which is nice and light blue and not inflamed at all, becomes very inflamed because the body gets an inflammatory response that then becomes autoimmune, and the body starts to attack the capsule or the lining of the joint. But the good thing on this though, again, almost all of these are treated without surgery. Can you play on that video for me? Again, this is a different type of injection. Each of these injections that I'm showing you are different types of injections. This one's going deep in the joint. All of these patients get an injection in my practice, and then if they fail probably 2 injections over a period of 3 to 6 months, then we may need to go into surgery. This is the one time in my practice when it comes to therapy that it probably needs to hurt a little bit, because we have to stretch that capsule. So the shot here allows you to tolerate the pain of the therapy, but it also will help you get motion back because it breaks down that inflammation and stiffness. If you have to go to the operating room though, we do it again through the scope, and we take this little lining of the joint and we'll actually use a little cautery device, and we'll cut the capsule and open it up and then get it moving right away. Calcific tendonitis is another one that we see very commonly. This is something where an ultrasound and x-ray are generally better than an MRI. So people will come to me with an MRI alone, and then I say, well, I need to get some x-rays, and they kind of say, well, why? I already have an MRI that tells you everything you need. A lot of times it's hard to see calcium on the MRIs. MRIs are meant to see soft tissues, so the x-ray can show me, or the ultrasound can show me a little bit better. And what's happening here is that the patient, for some unknown reason generally, is literally just depositing calcium into the soft tissues of the lining of the rotator cuff or in the cuff itself. Other folks have some form of a predetermined genetic condition that causes this, but we don't know much about it. The good news though, again, non-operative management is generally the way to go. So coming in to see your shoulder surgeon doesn't mean we're going to be getting an MRI and operating on you right away. Anti-inflammatories injections, something called needle barbitage is pretty cool, where I can watch the little lesion on ultrasound. I then stick a needle inside the lesion and I try to drain the calcium out of there. It's like toothpaste. Sometimes we can drain it enough that we don't need to do surgery. And then if we do have to do surgery, usually what we have to do is go in with a little shaver, shave it down, clean off the cuff, but sometimes we end up creating a rotator cuff tear, and now we have to fix the rotator cuff. So it's a pretty tough problem that way. This is the needle barbitage, where we put the ultrasound on the shoulder, we put our needle directly into that area. We do that in the office. We don't have to take it to the operating room, so it's a nice way to treat it. The last thing that I see is, we'll talk about today, is shoulder fractures. Usually this is just a fall from standing. Now it can happen from a car accident or a fall from height, but usually it's just an older person that trips and falls and breaks their bone. So most of the time this is happening in an elderly person with poor bone quality, but all fractures are not created equal. All people are not equal. So every fracture is treated a little bit differently. Obviously this patient has a break here that's in 3 or 4 parts, but it's still in pretty good alignment. Whereas this patient here, the humeral head is actually dislocated into their armpit. This part here is broken this way. So it's in 3 main fragments that are nowhere near each other. Obviously that's not going to get better on its own. Am I about done with time? You're doing good. Most of the time these are still going to be treated non-operatively. Usually these are happening in patients who are low demand. It's your grandmother, it's your elderly family member. If the alignment is in a reasonable position and they don't have a whole lot of requirements of that shoulder, commonly we can treat them without any surgery. But as you get younger and more active and the parts are more displaced, those are the ones we're likely to operate on. And there's 3 ways that we can operate on these. One is to fix it, where we literally just go in with plates and screws, as you can see here on the left. And this patient, it was actually so bad we had to put a graft in there. There's a cadaver bone in the center that we build the bone around. And then this is the plate with all the sutures that pulls the plate down and holds it there. The next one is a replacement, just a standard ball and socket joint. Sometimes we get in there and the tear is so bad, or the injury is so bad, and they have a rotator cuff tear, that we'll do a reversed replacement on the top right again, just like we would for arthritis. So in summary, there's a lot of reasons for shoulder pain, okay? I didn't even go into all of the details of dislocations and labral tears, all these other things that can happen. These are the most common ones that I see. The shoulder's a little bit of a black box because it's so mobile. There's so many things that can go on. You really should probably be seeking a specialist in this, okay? At least a sports medicine specialist or a shoulder specialist. Your generalist isn't going to have as many weapons to go at. Most of these are treated non-operatively, so don't be scared to come in and see us. Cortisone shots don't hurt that much, and they work pretty darn well, and they are covered by insurance. So don't suffer, go see your doctor. This is my family. We just went on our first Disney cruise recently, and that's when we got on the boat. And then after 4 or 5 days locked up on a boat, that's what we turned into. So it didn't take us long to get there. One comment on the stem cells, like Dr. Armagani talked about, I spend about half my day now talking people out of stem cell injections. And the thing that I always tell patients is like Dr. Armagani said, you want someone that's practicing what we call evidence-based medicine. So things that are supported by data. Okay, you don't want patients doctors experimenting on you. The other thing that I tell them is that if a doctor replaces your shoulder, we might get $1,500. No one wants to talk about money, but let's be honest, we get about $1,500 to replace your shoulder. The average patient thinks we get paid 10 grand to replace the shoulder. It's not true. It's about $1,500. One stem cell injection ranges from $3,000 to $5,000. That's what that doctor's getting for a shot. There's a lot of motivation for doctors to do those shots, okay? Money's a big motivator. We have almost 50 doctors in our group, and there's only one guy that does really many at all, and I think he does them because patients want them, So I spend more time talking to patients to convince them to not spend that money. Do your therapy, do your injections, do things that are tried and true. So that's the last thing. Yeah?
What about acellular exosomes? Next generation stem cells.
So like placental walls and stuff like that? Yes, amniotic fluids. Yeah. So that's kind of, to me, that's just the next iteration of stem cells. I mean, again, we're really shallow on the data on that. At best, it seems to be a good anti-inflammatory. That's it. All these things seem to have some anti-inflammatory effect. And that's good because it decreases pain, but it sure stinks when 6 months later or a year later, you're right back where you started. We cannot grow a rotator cuff, okay? We cannot grow cartilage with any reliability. Those things are just not there yet. So a friend of mine is a very big researcher in Stanford. He's actually a world-renowned researcher in stem cells. He only does stem cells on his patients that are in his trial. And again, he could get paid a lot of money to do this, and he still doesn't do it because he's not there yet. So he's doing it in patients that are in his trials. Those are the ones he's doing it on. Yeah.
Cuff, let's say 20 years, and learn to live with it. Does it still pay to see a doctor and see if there's anything else that can be done?
I think it's always good to get educated. Okay, so yes, I would say it would definitely be worth seeing a doctor. If you've had a tear for 20 years and you're living with it and you're not adversely affected by it, I would never tell you to have surgery on it, that's for sure. Now maybe a little bit of therapy can increase your quality of life. So that's why I think it's good to see what we're talking about. Make sure we're talking apples to apples, because your rotator cuff tear is not the same as his rotator cuff tear, and you two are not the same. So just having that discussion is very helpful.
Questions? We got the open mic now. So any questions for Dr. Baker? No.
Make it work.
You do for the hip replacement too?
I don't do knee replacements anymore. We try to be very specialized at FOI, so I only do shoulder. I do everything in the shoulder from start to stop, and I only do knee arthroscopy, so I do the sports stuff in the knee, so ACLs and stuff.
Anyone else? Questions? I expect a lot more of that. All right. Can everyone help me thank Dr. Baker?
Thanks, guys. Appreciate it.
If you do have any questions, he is hanging around. So if you want to ask him a one-on-one question,
He does have associates that
feel free to come up to him. And thank you all for coming with us. We are not done with our event yet. We do have still Darren Brooks, NFL All-Time Hall of Famer. He's going to be down there in about 10 minutes, and we will be finishing over there. We're also going to do prize drawings. So you're able to get tickets, whatever was in there. We're going to be doing the grand prize drawings right when we get over there in about 15 minutes, right at 12 o'clock. followed by lunge, and